Next, I invite Dr. Rehna Rasheed from Amrita Hospital. She will be presenting a case of retinitis.
Good morning, and thank you, Dr. Risha. So it's a disguised ocular toxoplasmosis. So my patient is a 20-year-old female who presented with progressive blurry vision and floaters in the left eye for the past 6 months. So her history is 6 months back she had started these symptoms and she was evaluated outside, found to have uveitis and was started on systemic corticosteroids. Medical background, there's a history of suspected SLE as per the patient, which was diagnosed 3 years earlier and started on medication, but she didn't continue. So this was her treatment course before coming to us. She had a vitreous tab done and gram stain and KSOS was negative. No further results available. She also had 2 doses of intravitreal triamcinolone 3 months apart. And 1 week before her visit to us, she was given Bactrim, which is a combination of sulfa and trimethoprim. And she developed cutaneous rashes, facial swelling, and elevated hepatic enzymes, which required medical admission. So that was suspected sulfa allergy. So on examination, her visual acuity in the right eye is 6.6 and the left eye is 6.9. Anterior segment right eye was normal, intraocular pressure was normal, and the left eye, there were cells in the anterior chamber, and visual acuity was 6.9. Intraocular pressures were fine. Fundus in the right eye, there was a chorioretinal scar infranasal to the disc. And in the left eye, the disc was blurry, there was extensive retinitis with hemorrhages, vessels were sclerosed, and the retinitis were extending to the mid-periphery and beyond. There was a scar superiorly with some pigmentation around. There were some deposits of triamcinolone which was seen inferiorly in the fundus, and there was very mild, that is grade 1 vitritis. OCT, there was no enema. We could confirm this whitish opacification which is due to the retinitis superior to the disc. So at this point, the differential diagnosis were acute retinal necrosis, CMV, and ocular toxoplasmosis. ARN, but there was no vitritis, but extensive retinitis was there. In CMV, usually presents in patients who are immunosuppressed, which this patient was not, and it has a granular appearance compared to our patient, which had a thicker retinitis. And ocular toxo was considered because of the presence of the scar in both the eyes. But the atypical feature was that there was no vitritis and the retinitis was extensive, unlike the toxoplasmosis, can occur in immunosuppressed. So she underwent vitreous biopsy, and the sample was sent for HSV, VZV, that is varicella zoster, CMV, which was found to be negative. Toxoplasma came to be positive, and serologically also toxo IgG turned positive. So she was diagnosed to have retinitis due to toxoplasma. So she was started on treatment with Clinda 600 TID. Sulfa was not given due to suspected allergy, and pyrimethamine wasn't available. So steroids were continued, topical steroids were continued. Because of the past history of this SLE and all, she also had a rheumatology evaluation where ANA and anti-dsDNA was found to be positive. Their clinical diagnosis is undifferentiated connective tissue disorder, and methotrexate was also started. So this is her after 2 weeks of treatment. You can clearly see that the retinitis is improving. There is this area, and this area has improved a lot, but still significantly it is there, but the vitritis started to get worse a little bit. So this is at 6 weeks. This is the initial picture, and this is at the 6 weeks picture. So we can see that definitely retinitis have come down, but still there at 6 weeks, and the vitritis has worsened, and the visual acuity from 6.9 has dropped to 6.18. So this is a last picture, the last follow-up, and she's yet to come for further follow-up. Here we have advised, maybe she was on tapering of steroids, so increase the steroids and intravitreal clindamycin, but she hasn't come yet. So I reckon this patient probably would have presented with a phenotype of autoimmune kind of posterior uveitis and was started on steroids, but with the presence of steroids, the toxoplasma would have reactivated, and with the intravitreal triamcinolone, it would have spread relentlessly to have an atypical picture like this. So I would like to ask the expert panelist whether we should have done differently or how should we go further with this patient. Thank you.
Thank you, Dr. Rehna. Madam, your opinion regarding this ARN looking toxo lesion?
Okay. I have a very similar case. Okay. Yeah. Same thing, given IVTA twice and presenting with very extensive atypical toxo. So what was the indication for giving IVTA? What was the indication?
I think probably the patient would have presented kind of a posterior uveitis kind of picture. We don't have the initial picture with us.
Right.
So
Nothing from the notes either.
only some papers which say what the procedures were done.
But
That's
not
all.
the indication as
No.
such. No findings. as
Most
such.
likely that small retinitis lesion might have missed.
Yeah.
And considering it as intermediate uveitis, they might have given.
And with the history of autoimmune disorder, that
Yeah.
probably would have been taken as an autoimmune kind of thing.
Can you go back to the initial slides where we have put ARN versus CMV versus toxo? So the first thing is that, do not make the assumption that, because a patient has a systemic autoimmune disease, that whatever uveitis that comes to you is directly related to it. On the other hand, I think if the patient is already immunosuppressed, if the patient is on immunosuppressives or steroids, you need to really worry about infection, right? The second thing is, if you ask me whether this is ARN, this is not the picture of ARN. ARN's lesions start in the periphery. Okay, this one is in the mid-periphery. So that goes against ARN. Can you come back to
This is
the,
initial.
yeah. And the fact that, there are scars in both the eyes, again, should have been a clue. There's one in the right and one in the left as well. Next one. Go on. Hold. Go back. Hold. CMV retinitis, happens most commonly in immunocompromised patient, but you also should know that there's something called local immunosuppression. If you give IVTA or a deposteroid into the eye, it is... It's okay. It's well known that, you can get reactivations of toxo or even viral retinitis. So I think the clinical picture, actually favors atypical toxo, and you did the right thing, going ahead with the vitreous biopsy and the PCR. The only thing is a lesion like this, I think needs combined therapy, with systemic as well as intravitreal clindamycin, and I would also give dexamethasone. My patient also, had the same problem of the vitritis, worsening, as we tapered the steroids. So we actually managed with combined therapy.
Okay,
Serial intravitreal clinda with dexa along with my patient was okay with Bactrim, so Bactrim and systemic therapy. So the take-home message is, be very, very careful, injecting depot steroids into an eye when you're not sure of what lies behind. And the other thing is, the patient was referred for rheumatologist evaluation.
The patient was actually presented to a hospital as an emergency with the facial swelling and all, and then was referred. The patient was referred to
Sulfur
Rheumatologist.
allergy, they suspected.
Yeah, but the patient was diagnosed as CTD, right? Connective tissue.
Undifferentiated connective tissue.
That is because ANA was positive and
Yeah, yes.
ANA and dsDNA were both positive. Yeah, so when you're trying to manage infectious uveitis and the patient also has systemic immune-mediated disease, you really have to get in touch with the rheumatologist. I would have actually advised them to defer methotrexate and used only steroids, to control the disease. Yeah. I would have waited for a good clinical response and then, ask them to start methotrexate if needed. Although methotrexate is very slow acting, it takes about 3 months for it to act. But even then, in such a situation, it is better to use steroids to control the inflammation in the eye. And there's one more thing. And you need to put this patient on Bactrim prophylaxis.
Bactrim.
prophylaxis.
Okay, but this patient is, I'll have
Oh,
allergy to sulfur.
sorry. I missed that. If she wasn't, if this patient
Yeah.
wasn't, then definitely needs prophylaxis.
Okay.
Which drug? Azithromycin or clean?
So if there is sulfur allergy, because this patient is going to be on metho probably for a long time, so just continue with azithromycin then because of the sulfur allergy.
Use azithromycin, but if the patient was not allergic, I would definitely put the patient on Bactrim prophylaxis.
And close follow.
Thank you.
And Dr. Archana?
I have used azithromycin prophylaxis in patients with sulfur allergy, so just 500 milligrams once a day for like 3 days a week, so
3 days.
alternating, or sometimes even 250 milligrams, because as a prophylaxis dose I'm taking, sometimes it can be quite difficult on the tummy. Patients have actually reported like gastric discomfort. So. What was the patient's intraocular pressures on presentation,
It was
Rehna?
normal.
Normal, okay. It's just that when you can also get clues if the patient presents with hypertensive uveitis, it's mostly pointing towards a viral etiology or toxo. So be aware of that. So high intraocular pressure with posterior uveitis or any uveitis, so to say, is pointing towards an infective etiology. And please stay away from injecting any intravitreal steroids without ascertaining the diagnosis and ruling out infections. And you shouldn't be hesitating or have a very low threshold in doing a TAP. And especially in immunocompromised patients. This patient, I believe she stopped the methotrexate, didn't she? And then she was not on any immunosuppressants.
No. Not on
Again, if any patients on immunosuppressive medications or immunocompromised patients, so to say, like patients with HIV, etc., or malignancy, so to say, you definitely need to do a vitreous TAP because you could be dealing with mixed infections as well. So it might not be just toxo or just virus, it could be dealing with a mixed infection. So just to highlight the point that you definitely need to consider the TAP. Yeah, thank you.
Thank you. So to summarize, before labeling a patient as anterior or intermediate uveitis, do a thorough indirect ophthalmoscopy and rule out any infectious pathology before treating a patient with intraocular or periocular steroid.